We're going to discuss pulmonary embolism. So pulmonary embolism, simply stated, is a thrombus in a large vein that originates in a large vein and travels to the lungs. And important to understand, this is in the vascular supply of the lungs. This is why it's in the vascular section. So this is in the blood flow to the lungs, not in the alveoli themselves. So it's not in the airways, it's in the blood flow to the lungs. So in this case, you have a clot, an embolus, and an embolus can be a variety of things. It can be coagulation factors, it could be a little portion of fat, it could be an object that is somehow managed to make its way into the bloodstream. So it moves from an area of larger vasculature in the body, and then as it moves through the bloodstream, it collects coagulation factors and produces a thrombus as these coagulation factors stick to whatever the original clot was, much like a snowball. So if you imagine, a basketball-sized snowball being rolled down a hill, and it just picks up snow as it falls. So similarly, the thrombus, whatever the origin, whether it's fat or whatever, picks up coagulation factors as it moves through the bloodstream. It moves through the heart and then moves into the pulmonary vascular bed, where it occludes a portion of the pulmonary vascular bed or pulmonary vascular circulation. This produces what's called a pulmonary embolism. So pulmonary embolism can be difficult to identify. The symptoms can be diffuse. The symptoms, if they're not diffuse, they can be mistaken for other things. They can be dismissed as minimal. So obviously that depends on the size. We'll talk about that as we go a little further. Now, as we move into this topic, there are three components that are critical in the understanding of the formation of pulmonary embolism, and also important for us as healthcare providers to understand our role in helping prevent them or manage them and address the problem issue with whatever is the cause for the specific pulmonary embolism. And those three things are the components of what's called Virchow's triad. Virchow's triad is a three-part component that highlights the main contributions to the formation of a clot. The first of which is stasis of blood. Anytime blood is static, if it is not moving, it has the potential to clot. So if you think of something we do for every patient that walks in the hospital, that's venous thromboembolism prophylaxis. Because when someone walks in our doors, the first thing we do, if they're coming to the emergency room or anywhere they access the hospital, we put them in a hospital bed. We put them in a bed, and then often we will limit their mobility. Now, in healthcare, we strive to optimize mobility, but in most cases, the condition that brought them to the hospital warrants a degree of rest. And so that's going to limit their mobility, which subsequently creates the potential for blood stasis, because people are in bed, legs are up, and they're not walking, moving around. And it is the act of walking, actually using our feet to balance ourselves and walk, that helps prevent the stasis of blood in our calves and our lower extremities, that helps prevent the formation of deep vein thrombosis. This is why when patients come in the hospital, we put them on some type of venous thromboembolism prophylaxis, whether it is an anticoagulant or the inflatable stockings that fit on people's legs to help squeeze the legs, or if it's compression socks or TED hose. So all of those components help address this first aspect of Virchow's triad. The second are conditions that could alter a patient's or an individual's coagulation. All of the things listed here: protein C, protein S deficiency, pregnancy, birth control. By birth control, I'm referring to contraception, factor V mutation, antithrombin 3 deficiency, malignancies. All these can affect the coagulation of the patient. They can affect liver function. They can affect all of these components that contribute to coagulation. In this case, our concern is about hypercoagulability. And what I mean by that is hyperclots, or the patient is prone to clot formation. Anything that would change their metabolism such that would make them more prone to clot. And conditions like pregnancy, the hormones that are released as a part of that process, in addition to the additional blood flow, and contraception, so those hormones that we administer to mimic the body, to convince the body that it's pregnant, can potentiate coagulation. So all of those things, anything that's an alteration to the metabolism that affects coagulation. That's the second piece. The third is any kind of abnormality of the vessel wall. Now, this is really a quite broad statement. If you think about what causes a clot to happen in your body when you get a cut. So if you cut your hand, what will happen is you have obviously a trauma to the vessel wall. That's why you're bleeding. Well, that trauma is an abnormality in the vessel wall. That abnormality in the vessel wall will attract blood, clotting factors that will stick to that interrupted area. And that area then where those clots stick, they become more static. And so stasis is a contributor there. And as that clotting factor around the injury produces a barrier, other clotting factors stick to that, produce a clot, and heal cuts. That's part of the way we heal. Well, unfortunately, abnormalities in the vessel wall as a result of vascular disease, such as plaques or changes in the structure of the arteries themselves, conditions like diabetes, which affect the texture and the quality of the vessel wall, inflammatory processes that create inflammation or irritation of the vessel wall produce an opportunity, an abnormality that coagulation factors can adhere to and subsequently adhere to themselves and produce an embolism or a thrombus. So all of those components are the key components to the formation of a pulmonary embolus. Now, the most common culprits associated with pulmonary emboli are, as I've mentioned, deep vein thrombosis, which is a clot that's formed generally from lack of movement or poor mobility, or perhaps, as has come to awareness more recently in our culture, is long, potentially, or overseas flights where people sit for a protracted amount of time. Those factors contribute to the formation of a deep vein thrombosis. Also, trauma, specifically long bone fractures. So these would be bones like the femur or humerus, long, big bones. Those bones, and obviously the larger the bone and fracture, the more likelihood there is for the formation of fat emboli. Those bones have a higher propensity for the formation of a fat embolus. Those fat molecule particles, fat emboli, can make their way into the vascular bed, that vascular supply, through the bones themselves. Those large bones are highly vascular, and those fat pieces can make their way into the blood supply through the bone and then out into the bloodstream. So those can be those are the two main contributors to the formation of pulmonary embolus. Now, with a pulmonary embolus, size matters. So a small emboli, the smaller the emboli, the further it's going to travel into the pulmonary vascular bed, pulmonary capillary bed, the further it's going to go, which means it's going to lodge itself in a smaller region of the lung and therefore affect a smaller amount of tissue. So a small pulmonary embolus could go unrecognized and not even be associated with a pulmonary embolus. Chest pain in a situation like that could be minimal. The individual could attribute it to something else. Something that comes to mind is someone who exercises frequently could conceivably have a small pulmonary embolus. They're fit, so they have a high capacity for compensation. They notice on a particular workout that, I noticed I was a little short of breath, but I didn't really think that much about it. It was, I just thought I had worked a little harder, or it was a little more humid, or whatever. Could attribute it to environmental or biologic conditions, not thinking about a pulmonary embolus, and then subsequently find out down the road that they may have had a pulmonary embolus at some point in the past. That's conceivable. Most commonly, patients who manifest with a pulmonary embolus have not had those type symptoms before, and they're concerned about it. They may have some chest pain associated with it, and they come to the hospital, and an embolus is identified as a part of the rule-out process for other things such as a myocardial infarction. If a patient, even you could see where, let me back up just a moment here, you could see where conceivably, while a small embolus might not be one small embolus might not be a big issue. If someone had multiple small emboli, then you have larger surface area of the lung that's affected over time or at the same time. And you have the result, basically, of a large embolus. You just have it in several small ones. So that could, in fact, create an issue. And as the pulmonary emboli evolve, that could contribute, and that effect on the lungs could precipitate a condition called pulmonary hypertension, which we will get to in a few videos. So a medium-sized emboli, these are the ones that most commonly produce some degree of symptoms that someone will present with, and that's going to most commonly be, there's going to be some shortness of breath. A common symptom associated with pulmonary embolus is chest pain. This chest pain can have a variety of descriptions, from a pleuritic type pain where it hurts worse with inspiration, to a heaviness in the chest that can mimic cardiac chest pain. So they can have a similar sensation description to the patient. And for those reasons, often 12-lead EKGs will be performed, and possibly even CT angiography to rule out cardiac issues. We'll get to visualization momentarily. But dyspnea, sometimes a bit of a fever, all of those can be symptoms. Patients have had a blood-stained sputum. That is not it doesn't mean it happens all the time, but it's not completely uncommon for a patient to have a blood-tinged sputum. Obviously, productive cough there. The emboli could potentially produce a pleural friction rub, which a pleural friction rub is when the pleura, because of inflammation, is rubbed. The visceral and the parietal pleura are rubbing together, and that creates the sound very similar to like sandpaper. If you were to take sandpaper and fold it and rub it on itself, it's a scratching sound. The key distinction for a pleural friction rub is that it stops when the person quits breathing. So if someone holds their breath, the friction rub goes away. That's the key criteria for being able to distinguish a pleural friction rub from a pericardial friction rub. A pericardial friction rub will continue even when the individual is holding their breath. So chest radiograph and chest X-ray is often will often be done. Currently, the most diagnostic, the fastest and most diagnostic test for pulmonary embolus is a CT scan. That's the current leading edge. So with massive pulmonary emboli, that can produce hemodynamic compromise. It can produce cardiogenic shock. It can produce respiratory failure and an acute life-threatening event. So patients can report chest pain. They could then obviously be pale and with poor oxygenation saturation, and maybe hypotensive, possibly a weak pulse, neck vein engorgement. The neck vein engorgement makes sense if you think about this anatomically, because with a large, massive pulmonary embolus, the large structures coming off of the right ventricle here are obstructed, and blood coming into the right ventricle has nowhere to go. So it's going to back up into the jugular veins. And a massive pulmonary emboli can definitely be a fatal condition. So sometimes you will hear a massive pulmonary embolism also referred to as a saddle pulmonary embolus. So if you look at this picture, I'm going to show you this and then go back for just a second. This is a picture of a patient with a large massive pulmonary embolus, effectively a saddle pulmonary embolus. Back to this picture, if you notice the structures here in the center of the screen, you have the right atrium, then the right ventricle. And as you follow this arrow out of the right ventricle into the pulmonary artery, you have the left and right pulmonary arterial branches. And this place in the center, you can imagine where if you had a clot that was sitting in this center portion and blocking both of these, that it would appear on an x-ray or some type of imaging as a saddle. So if you imagine a clot sitting right in here, then it would very much look like a saddle. That is where that language of saddle pulmonary embolus comes from. Now, this particular massive embolus here was referred to as a, quote, saddle PE, but you notice it doesn't look like a saddle. However, because of the major vasculature blocked on the right here, as well as a majority of the vasculature on the left was occluded also, this patient basically essentially had the equivalent of a saddle pulmonary embolus. Fortunately, this patient was intervened on and survived. You can see here from the placement of, these are the actual thrombi from a patient laid out on a graphic image. And you can see that this right side is essentially 100% occluded. The left side is occluded except for this branch off of the left pulmonary artery that goes up. You can see that branch is open. This branch is also receiving blood flow, possibly portion of this. So this portion of the lung up here and a small portion of the medial lobe on the left is what this patient was living off of. This embolectomy was able to revascularize the patient and produce a good outcome. So as I mentioned, for pulmonary embolus, there can be a wide variety of clinical presentations from shortness of breath, chest pain, to just perhaps anxiety and some tachycardia that they can't explain. It is more common than not that patients will have some degree of chest discomfort and definitely report shortness of breath. Characteristically, the shortness of breath comes, as I have in quotes here, out of nowhere. So commonly patients were fine up until the moment that all of a sudden they cannot breathe. Some people will say, it's like I'm exercising, but I'm not. I'm sitting still. And it just comes out of nowhere. It's very abrupt, commonly in onset. The chest pain, as I mentioned, if they have this, it can mimic angina. It can also have a pleuritic component. This is part of what makes the pulmonary embolism patient challenging to identify immediately, because we have to differentiate from angina and other sources of chest pain. They may also have tachycardia. You could see where if a patient had vascular occlusion, like the image I just showed you, they need to compensate. There's a huge portion of the lung that's not able to produce oxygenated blood. So the body is going to attempt to compensate by increasing output and increasing respiration in order to try and improve oxygenation of the tissue. And as a result, patients are going to often complain or demonstrate, I hate to say complain, but demonstrate anxiety, apprehension, restlessness, and perhaps sometimes even a sense of impending doom. If they have a cough, they could perhaps have hemoptysis with that cough. It doesn't necessarily produce a cough, but that could be what is demonstrated. Now, historically, as far as diagnosis of pulmonary embolism, the gold standard for the diagnosis of pulmonary embolism has always been a pulmonary angiogram. A pulmonary angiogram is when we take patients into invasive radiology and interventional radiology and inject contrast into their pulmonary arterial blood flow. And that allows us to directly visualize the location of any thrombi in the pulmonary capillary bed. Now, the challenge there is while this is the gold standard, it does take time for this to happen. It takes, you have to have an interventional radiologist available. So if it's after hours, someone has to come in. You have to get the room prepared. You have to get the patient prepared, get vascular access, et cetera, et cetera. So you can see where even as moving as fast as we want, there's going to be some degree of time delay. And I'm not talking hours. However, currently, chest CT is more efficient in diagnosing pulmonary embolism diagnostically than is just doing a pulmonary angiogram. Now, pulmonary angiogram and subsequently thrombectomy is the treatment of choice in the direction that will ultimately be followed. When a patient walks in the door complaining of shortness of breath and chest pain, you can see, hopefully you can see where if I take this patient and perform a 12-lead EKG, I order troponins, and we go for a chest CT. A chest CT takes about 5 minutes to do. It takes about 5 minutes to 10 minutes to get there, depending how far away the CT scanner is. So you could see where within 30 minutes, we could have potentially an EKG that points in the direction of angina or not. We could have tests waiting to be finalized in the lab, and we could have performed a CT scan wherein a radiologist could either rule in or rule out a pulmonary embolus within the scope of easily 15 to 20 minutes if everything's running efficiently and on time. That said, it would take at least 20 minutes to get access to the femoral artery to begin the pulmonary angiogram. So you can see how CT of the chest can provide a very rapid diagnostic test to rule out or rule in pulmonary embolus. CT angiography is currently a form of CAT scan that is evolving currently. More and more centers are doing these because they actually provide a CT image, but more than that, they provide 3D visualization of the vascular bed so that we have really not just CT slice images, we also have a three-dimensional depiction of what that pulmonary anatomy looks like and where the blockage is. So it's much more specific than plain CT. The challenge is you have to have the equipment and the software that does it, and you have to have a physician that knows how to interpret those exams. I do know that this is CT angiography is something that they do at Mercy. I'm not sure what other hospitals in town do CT angiography. I wouldn't be surprised if Washington Regional also does. In the past, a VQ scan, V for ventilation and Q for perfusion, was the classic test, but this test takes time. It takes a good 20 or 30 minutes to perform the test, and the test results can be murky. They may not necessarily be clearly diagnostic. They can have both false positives and false negatives, and the results, if it's neither one of those, can sometimes be non-diagnostic. So that used to be the standard that we would work toward, but it's fallen out of vogue. over the last couple of decades, actually. A 12-lead EKG can reflect tachycardia and have non-specific changes on the EKG, which both kind of helps and kind of does not help. We expect to see tachycardia, but there aren't specific changes on the EKG that purely identify pulmonary embolism. So this is something we do mainly to rule out or rule in a cardiac cause, which takes the patient down a different path if they're having an acute myocardial infarction, particularly ST segment elevation MI. I mentioned before these patients can have hemoptysis. That's a corroborative finding as a part of the diagnosis. A chest x-ray can be normal. There may not be anything that shows up necessarily on the chest x-ray. And in the earlier phases, when the patient is compensating, arterial blood gases can be normal. Left untreated, this is not going to remain this way. Eventually, the patient will deteriorate left untreated. But in the initial phase, early enough, the blood gases could be normal. So what's the treatment for this? First of all, we're going to provide the patient with oxygen. Often we'll provide oxygen even if the patient's saturations are still okay. If you think about this somewhat makes sense because there's a portion of the patient's pulmonary structure that's not getting blood flow. So the lung parenchyma portion of it is not getting blood flow. That means it's not oxygenating. So for these patients, whether they have shortness of breath or not, we want to provide them with oxygen so that we can optimize oxygenation of tissues to compensate for the portions of the lung that aren't exchanging oxygen. So that's an initial treatment. It's not the end all. As we think about treating the problem here is the thrombus or the embolus, and we have to address that thrombus. And thrombolysis is an option. Thrombolysis in the form of a chemical such as tenecteplase or some other form of fibrinolytic agent, alteplase, tenecteplase. These are medications that dissolve clots. That's what they do. And we can administer these. Now, fortunately, a medication like tenecteplase is TNCase, you may hear it called, is a drug that can be kept on the shelf undiluted for a long time. This is great for remote centers. If you're 3-4 hours from a major center that can perform a pulmonary thrombectomy, then you can potentially get life-saving treatment in the form of a thrombolytic in these remote ERs. They just mix this up, give you a weight-based dose, and it could potentially dissolve the clot completely, or perhaps dissolve it enough to keep you from sustaining any serious damage while we're transporting the patient to a tertiary care facility. Now, in places like Washington Regional, Mercy, St. Francis and Tulsa, hospitals in Springfield, in these tertiary care facilities, they will go in to do either a thrombectomy or some form of thromboplasty, where they advance catheters in the area of the clot and try to extract the clot, like you saw just a moment ago, or open the artery if they can't extract the clot. Now, once they've done this in that area, what they will do, particularly if they're in a location, a hospital that does this kind of treatment, they'll use a catheter that has openings at the tip of the catheter and place that catheter in the location of the thrombus and infuse a thrombolytic directly into the bed of the clot. This will provide a much lower dose of thrombolytic directly to the place where the clot is and allow the thrombolytic to dissolve the clot at the spot without the entire patient receiving a thrombolytic. Thrombolytics are not discriminatory, so they don't only do stuff in the lungs or at where the clot is. They do their clot busting anywhere that there is a clot. So there are some contraindications to this kind of treatment, and that has to be considered. The ultimate treatment, thrombolysis, is one component of that treatment. The ultimate treatment is thrombectomy, where we actually remove the clot, like you saw the images just a moment ago, where we actually remove the clot and extract them. Anticoagulation plays a role, and that is in order to prevent further clot formation, especially in the immediate acute period, and depending on the patient's risk factors and the severity will depend on whether they're chronically on some form of anticoagulation. And I have listed here some of the anticoagulants that are used and the components that they act on in the clotting factors they act on in the body. And we'll talk about some of their strengths and weaknesses. So heparin is easily used at the hospital. It's easily managed either subcutaneously or IV. It can be monitored and adjusted every hour to every 6 hours to maintain an optimal anticoagulation. What we're trying to do with heparin, warfarin, all of these is prevent clot formation. These drugs don't break up the clot. They prevent compounding the clot. So we'll place patients on heparin, sometimes IV, often IV, sometimes subcutaneous, depending on the severity and risk, and then monitor heparin with lab tests to maintain that patient's heparin anticoagulation in a therapeutic range. And we'll measure anti-10A or 10A levels in the hospital to make sure that they're therapeutic. Those drugs, heparin and Lovenox, work on thromboplastin. That's why you will see things like a 10A performed, or you will see a partial thromboplastin time, PTT. Those tests monitor the efficacy and the level of anticoagulation with heparin. Now, warfarin works differently. It acts on thrombin, which is a different coagulation factor. So for warfarin, we use a prothrombin time. And most commonly now, in just about every center, we use an INR, International Normalization Ratio, which means that regardless of the components machine that you use wherever you are in the world, literally, whether you're in Peking, China, whether you're in Dubai, whether you're in London, or any other portion of the world, if you receive a test and it's an international PT-INR, International Normalization Ratio, a 2 in Peking is this, in Beijing is the same as a 2 in Dubai, is the same as 2 in London, New York, Northwest Arkansas. So an INR of 2 is an INR of 2. That is why we use INR to monitor warfarin. Now, what we've just discussed requires a degree of extra work and effort and monitoring on the part of both the provider and the patient. So heparin and Lovenox and warfarin all require diligence on the parts of the parties involved because of concerns about bleeding risk. That's why other drugs, like the ones I have listed below that, have been developed. One of the earliest drugs for the development of anticoagulation management on the outpatient basis was Plavix. It is a GP2B3A activator, and it inhibits platelet aggregation. So that particular that particular drug was developed to attempt to put a drug on the market that wouldn't require any lab testing and would provide safe anticoagulation. That was the first of this type of this objective, these type of drugs to be placed out there on the market because of bleeding concerns as a result of people being on warfarin. So those Plavix has come along, it's still used. You'll still see it from time to time for patients who can't take the factor 10A drugs like Xarelto and Eliquis, rivaroxaban, apixaban, indoxaban, all of those drugs. So all of those drugs work at factor 10A. They also do not require lab monitoring. You take a dose and it provides the anticoagulation that's needed. Those drugs are the kinds of drugs patients will leave the hospital on if they need ongoing anticoagulation after having a pulmonary embolus. So those will be outpatient ambulatory medicine drugs that you're going to see, but you'll see them initiated in the hospital. Now, if a patient were to have recurrent pulmonary embolisms despite being on apixaban or Xarelto or some similar drug, if they were to have recurrent pulmonary emboli and they are on the drug, or perhaps for some reason they can't take the drug, so if they have diverticulosis and episodes of diverticulitis and they cannot be anticoagulated, they may require the placement of an inferior vena cava filter. And this is exactly what it sounds like. It is a filter that is placed in the inferior vena cava. It's a net mesh-like material through which the blood can flow, but clots cannot. So patients who have recurrent DVTs, hopefully we can intervene on them, find them prior to them evolving into pulmonary emboli, and this can be monitored with sequential venous Dopplers of the lower extremities. If they're continuing to form or not going away, we put in an inferior vena cava filter, which will basically capture those clots. And because of the fact that they would also concurrently be on something like apixaban, those clots caught in this mesh will in time dissolve, so the filter doesn't functionally become all clogged up, if you will. So from a nursing standpoint, our primary concerns are nursing management. It's going to be, first of all, we're going to monitor for signs and symptoms of bleeding. These patients will have had some kind of major artery accessed and will have received some form of, if not fibrinolytic, at least an anticoagulant. So these patients are going to be at a higher risk for bleeding. That's going to be something that's got to be a number one priority for us. Their airways should be patent. So we think about airway management, that they shouldn't have a reason to have an occlusion. But we definitely also have to be considerate of their oxygenation, because while their airways are fine, remember, this is not an airway problem. This is a vascular problem. So even though it is a vascular problem, we need sufficient air ventilation to get oxygen into the bloodstream so that patients are adequately compensated if they were to have reocclusive type problems. So we are definitely going to be monitoring oxygenation and monitoring for a risk of bleeding. These two things have our highest priority. For these patients, we're going to identify lifestyle factors that increase the risk. And yes, smoking is going to be a concern here, so certainly. But we also have to bear in mind that there are other lifestyle factors that affect coagulation that have nothing to do with smoking. One that I mentioned earlier is contraception. So if we have a young female who's had a baby or two, and that's kind of been their goal in life, their family goal was 2 children, then she's on birth control because she feels like she is too young to have a permanent intervention like a tubal ligation. And she doesn't want to rule out the possibility they might want to have a third. We may have to have a different conversation with her about the ways in which she's going to manage contraception going forward in the presence of a pulmonary embolism as a result of contraception. And I will tell you a story. If you're watching this before class, you'll hear a story in class where this was actually an issue. So when I say lifestyle factors, yes, smoking, absolutely. Yes, alcohol consumption. Yes, contraception. We have to consider a variety of factors beyond just the normal things that do not contribute to overall good health. So lifestyle factors, we have to identify those things. We have to identify things in the diet that can affect coagulant therapy. So these patients, we need to find out if this patient eats just a ton of leafy greens and they're developing DVTs. We may have to discuss with them monitoring that, for example, or regulating that. We may also have to modulate that as we send them home on coagulation therapy, because those drugs that are high in vitamin K, or excuse me, medications, foods that are high in vitamin K can interfere or decrease the efficacy of coagulants that they are going home on to help prevent this problem. And then, of course, if they're going home, if they're on heparin or going home on warfarin, because that's what the clinician and patient have chosen, then there's going to be lab involved with that. And generally, patients don't go home on heparin. It's not completely unheard of, because heparin and Lovenox can be administered subcutaneously. It's just uncommon that heparin is used in a home management situation for pulmonary emboli. So here's a little case study, and this we will go over in class. So I invite you to review this, give it some consideration, and then we'll discuss the rest of it in class. And our next video, we will pick up with pulmonary